Okay, so what we're looking at today is how care coordination is being utilised in primary care. So I personally, as a care coordinator, I've been in post for 5.5 years now. I work in a team of 6. We all work collaboratively, but we all have completely different jobs per se in terms of what cohorts we cover. My background specifically is severe mental illness, care homes, learning disabilities, severe multiple disadvantages, and the general day-to-day running of the team as a whole. So, first off, what is a care coordinator? So, care coordinators play a vital role in delivering personalised care across primary care networks. The heart of the role is a simple but powerful aim to make sure people receive the right care at the right time in a way that truly works for them. We, as care coordinators, something that we regularly find is that you will more than not come across that people do deal with a completely different caseload to you as an individual. So, like I say, we support cancer patients, mental health, learning disabilities, care homes, LTCs, vaccinations, safeguarding, uh, medication. We support weight management. It's massive. It's huge. It can go on and on and on. There's so many different things that we can touch on. That's why that it kind of makes the care so personalised from whoever is delivering it, because everyone has to have their own sets of skills and their own understanding of whatever cohort they are delivering care for. So people will do different types of jobs when they're in care coordination. So it could be primarily arranging condition reviews, calling people, sending letters, sending texts, sending booking links, looking at ways to communicate with people to ensure that they're getting the best quality of care that they can by attending, screening, reviews, anything that they may need. We're encouraged to combine appointments to try and make people have to come in as little as possible. Not necessarily because we don't want them there, but so that everything can be dealt with in one, make it more sufficient for the actual patients themselves. We can create about me's, we can do personalised care and support plans for patients. It's a massive array of what we can do and what we can deliver for whatever cohort of people we deliver for. So I just think it's very important to understand that although we can seem like we are the same, we are all different in the ways that we work and the people that we deal with. So there's no specific definition for a care coordinator realistically, because it is dependent on your job role that you're employed to do. So again, just looking at different areas that we can cover, there's mass invitations, there's sometimes being an actual contact. So somebody that your cohort can contact, for example, cancer patients. Some people might actually act as the point of contact for their PCN, where the cohort of patients can contact you directly for any advice, any support, any appointments that they might need, follow-up, stuff like that. It's just another way of working to personalise care. We've been known to support COVID and flu vaccinations, carry out reviews. In my job within the care homes, personally, I go into care homes, I visit them, I do the reviews, I'll do the personalised care planning, I'll support the dementia reviews, I'll support kind of like frailty and falls assessments and stuff like that. So again, it's all about you as an individual and how you develop that role and use your skills to create personalised care for the people that you are dealing with. So that's just something that I try and communicate quite often, that no role realistically is the same. We can also look at obviously referring on to local services for weight management, talking therapy, smoking cessation, whatever people need. But again, completely specific to the people that you support. There is a massive misunderstanding of the care coordinator role, particularly within primary care. It goes on to link with quite a few different roles, but you tend to find that there's a massive confusion when care coordinators can be classed as admin in some cases. It's not necessarily the same admin as care navigation. So when you look at your kind of care navigation, there's reception work, there's repeat prescriptions, IT support, choose and book referral, social prescribing. These are all things that we can regularly be confused with and that we default into doing. Whereas these are things that do go more towards your admin and care navigation roles, but you do find a default of people employing a care coordinator, not necessarily understanding it, and these being the things that we fall into. Sometimes it's not a bad thing. It's all about how your primary care network developed the role. So obviously these are things that people can end up being in. Yeah, so that leads into the overview of the differences between care coordination and care navigation, because it is quite broad across care coordination that is the main one that we are confused with. Sometimes it can just be a confusion of the actual names because they are pretty similar. And it can just be a massive misunderstanding of the actual workforce development plan that Nikki did post earlier in the chat. So it might be worth referring to if you do feel that your role is being confused with the old care navigation side, to have a look through that and see obviously the differences and pinpoint what you're not quite doing, because that might be something that you want to communicate with PCNs to try and look at differentiating. So we have all the different things that a care coordinator should do, all the different things that a care navigator should do. So these are kind of the differences that weigh up the roles. So we have care coordinators tend to deal with their own cohort of patients, which I've explained, and we can do all sorts of things for them. So it is all about having a cohort of patients, whether this might be specifically mental health, whether it might be child safeguarding, whether it might be dementia. We all tend to have something that we deal with that we are kind of like the lead for. Whereas care navigators, which are receptionists and your general admin, some people would say it's just reception, but it isn't. It's the people that sit in the back offices and support obviously a lot of the background work, but they tend to be working with all patients. So they're the first point of contact for anybody that wants to come in, as you would imagine a receptionist to be when they're sat on the desk and they're taking the calls that are coming in for on the day appointments. It's that kind of work that is care navigation. So working, like I say, primarily on reception, admin, booking the on-the-day appointments, ordering medication. So ordering medication would technically be a care navigator's job, but actually dealing with the medication management and medication reviews and providing personalised care around that would be a care coordinator's job. Yeah, so care coordinators would work with specific patients to support their needs and make necessary referrals. So as care coordinators, we can make those referrals because we provide that personalised care, and we tend to get to know the patient's needs outside of the area that they're struggling with. So you might be supporting people with, let's say, cancer care, might be supporting people, but through getting to know that patient and just having those conversations, you'll be able to support them with other areas of health, such as weight management, smoking support, mental health support. We can kind of tailor that care to refer them on to where they need to be. Whether it is referring to for a social prescriber to actually take on that kind of thing, but we tend to be able to do the generic lower level referrals where they are needed. We tend to have the time to get to know the patients and their needs to create tailored and person-centered approaches, because that is something that comes up frequently when you speak about care coordination, those person-centered approaches, because it's about taking the person at hand and seeing what matters to them and listening to them and their needs and trying to support them the best you can through their healthcare. And you know, we are meant to have training on this. There is mandatory training that care coordinators are meant to do, including the person-centered support planning, shared decision making, and obviously the care coordinator course that Peak Health do. So we should be trained in doing those, and we should feel confident in obviously assessing people in that way and providing that kind of personalised care efficiently throughout whatever it is that we are employed to do within our own primary care networks. Back to care navigation, they will deal with kind of like acutely presenting patients, and they tend to just deal with the initial medical needs. So it would be somebody calling up and saying, you know, let's take mental health, for example. I'm struggling with my mental health. So the care navigator would take that call, book in with a GP, book in with an AMP, book in wherever they are, send a crisis number, whatever they need to do. It would be passed on. whereas your care coordinators would take that case on. If we were kind of like a mental health care coordinator, it would probably be the care navigator that would send them to us after they've seen a clinician for us to work with them to understand the mental health, to be able to arrange reviews for them and stuff like that. So on any support planning that needs doing. So that's kind of a broad overview of the difference between care coordination and care navigation. Yes, so that's that comparison. We have another majorly confused thing is the difference in ways of working between the care coordinator, the social prescriber, and the health and wellbeing coach. And as I said earlier, it tends to be that people get the roles confused, or primary care networks will take a care coordinator and expect them to do the job of a social prescriber. Or they will take a social prescriber, expect them to do the role of a health and wellbeing coach. And that is normally just misunderstanding. And it's knowing the capacity of each role and where you fit into. And sometimes there is overlap in the role. Sometimes a care coordinator will touch on social prescribing. Sometimes a health and wellbeing coach might slightly touch on care coordination, and that's not a negative thing. And that's nothing to say that that is taboo. It is good to have all those skills as a care coordinator to be able to support these, but it is important that we differentiate between the three roles because they are all there to support a different area of healthcare. So your care coordinators, the best way that I can describe this is that we are there primarily for healthcare. So care within a primary care network. Your social prescribers are there for the social side of it. So support with things like community support, getting people into community settings and, joining clubs that are nothing to do with healthcare, but they could support their health. They look at things like finances, housing. They can look at low-level mental health, and they kind of take on a case for a set period of time, which is normally 6 to 12 contacts per patient over a 3-month period. So it tends to be short term, but they work within the social side of things. Care coordination, we can take people on for life, considering what the condition is that they have, like specifically cancer care. You tend to have them rolling unless if people do beat cancer, which is it's the end result that we all hope for. But there's a lot of conditions that we will have rolling year from year. For example, myself with the mental health register, a lot of people tend to stay on it. So I see the same patients year in, year out because they're on that rolling register. So we tend to have essentially a more manageable rapport with patients because we're not short term. Or sometimes we are short term, which is fine, but we tend to see the same patients over and over again within a certain set period of time. So we will obviously help navigate the care through primary and secondary care services sometimes. So we're there to take on a case and, if they feel that they need a GP appointment, we can kind of coordinate into that and support them with that. If we can't book it directly for whatever reason, we'll be able to advise them on how to do so. We'll be able to support people by taking on a learning disability patient who, even though you're a learning disability care coordinator, they might need the vaccines. They might be eligible for a COVID vaccine, a pneumococcal vaccine. We take on that case and we try and help them with as much as we possibly can, in a way for the only telling the story once or only telling the story as little as possible it have to be understood, and to try and give them confidence in the support that we give and their own healthcare. So trying to make them a bit more self-managed with our guidance to be able to do so. Again, we act as a point of contact for whatever the needs might be, whether it can just be a quick question, whether it can be an assessment, anything. We should really be there for them for what they need, but know your boundaries of how much you can actually advise on and where things then need to go clinical, and advising obviously for seeing specialists in things like whether it is referring people onto a GP or another clinical professional. It's just knowing what to do with people in individual times, I guess. So we work around healthcare. We can create the personalised care and support plans. We can do reasonable adjustments for tailored care. We can support patients in an array of different areas, and we tend to collaborate quite well with outside services like your care homes, like smoking cessation, weight management. If we collaborate well with them, we can really provide as much personalised care as we possibly can by having good rapport and being able to obviously pass things over there. Your social prescribing, they tend to connect people, as I said previously, to non-medical community-based support services and groups just for like practical and emotional needs. And they tend, like I say, their annual caseload realistically is averaged 200 to 250 people per year, because they do kind of take cases on for a period of time, but they only tend to have the capacity to support so many. Again, care coordinators, we may only have the capacity to support so many people, but it again goes on to what you do as an individual job role. So yeah, I have put some things on there actually, if you can all see the screen, with the support patients with in terms of social prescribing, what kind of things they will support with. So you've got your loneliness and isolation, complex social needs, accessing the voluntary sector. So that tends to be what they base on, where we're more health-based. Your health and wellbeing coaches. So these are something, they're not in every area. So in Basset Law, we actually don't have health and wellbeing coaches. Their job role is kind of absorbed in a way between care coordination and social prescribing, with not much support for people that would require a health and wellbeing coach. But your health and wellbeing coaches, they support with your like more physical and mental needs, working alongside long-term conditions, and they use coaching skills and behavior models and a lot of positive psychology to guide people to meet their personal health and well-being goals. So they are very much focused around self-management and giving people the confidence to be able to support their own well-being and have better management techniques within their own care. But yeah, they work a lot with coaching, which obviously is why they're called a health and wellbeing coach. But yeah, so with care coordination, it is more important than ever at the moment. We tend to we are becoming a lot more established within primary care networks. We are being more defined, which is always a positive thing to see. But there is still a lot of confusion between roles, which I have just previously explained. But it's something we can work on, and hopefully it will start to unravel itself and become a lot more defined as we go on. The NHS long-term plan places personalised care at the centre of centre of future healthcare, recognising that people have better experiences and outcomes when they are actively involved in shaping their own care. Care coordinators are key to making this vision a reality, providing continuity, coordination, and compassion in an increasingly complex health and care system. And that's something to be mindful of when you are supporting patients, because everything is becoming increasingly more complex. You know, it should all be about continuity and coordination and compassion as much as it possibly can be. But obviously some roles are restricted, but that is specific to you as a care coordinator with the people that you coordinate. Yeah, so the result of all of this is, realistically, for anybody, should be a smoother care journey, empowerment, being more connected, and future ready NHS. And this is not just for the patients, this is for us as care coordinators, because we need to be future ready for the NHS. And I feel that this is something that we really do feed into, because we are coordinating people through the health needs and anything that they need. So we're trying to implement that as much as possible. And I just put something on the end because I love this. But in short, care coordinators don't just organise care, they humanise it. And that's something to take note of, because the whole point of personalised care is to humanise it. That's what we try to do. We're trying to make it more manageable. We're trying to make it more efficient. We're trying to encourage those people to take care in their own hands, have a better understanding, but not feel alone through it, and feel that they have people there that they can rely on and that they can relate to, that are there to support them, which in role is us as a care coordinator. So that is my presentation done. But just alongside that, I just wanted to say, obviously, we're all individual, like I've said throughout, but don't go away from this thinking that you're not doing a care coordinator's role, because your role is normally defined through the primary care network that you actually work for. So a primary care network will normally employ a care coordinator, and they will define what cohorts they need you to deal with. And this all goes on QoF, it goes on LES, it goes on DES, it goes on whatever contractual needs a primary care network does have. And that will differ massively for every single PCN, but it's just about how you take that. You look at the resources that you've got, you look at how many patients you've got registered within your PCN, and you see to what extent you can personalise that. And that's what we work towards.
Beautiful. Thank you, Darcie. That was a lovely presentation. And I think you've covered a lot of some of the dilemmas that people are holding. And I can see a lot in the chat there. And I think this is a real hot topic, isn't it? Is that, you know, NHS England has described the pure outline of a care coordinator role.
Mhm.
And there's clearly a real need for that person that humanizes, helps people's journey be smooth when it's complicated, and, empowers them at the same time so that core principle of personalized care, isn't it, is that people are able to be in control, making their own choices as much as possible. And often that doesn't happen in the NHS. People are dehumanized and pushed around. So you're fighting for a really important role. And I can say this as a PCN clinical director, I network with lots of PCNs around the country. You're also struggling against other pressures in the system, and practices are under a lot of pressure at the moment. They've felt a big squeeze on funding and a massive increase in demand since COVID. So, not surprisingly, they're also trying to pull resources into the practice to do some of the jobs that they think are essential in the practice, like getting people in for their QoF checks, getting people in for flu checks, making sure that people are having their blood pressures checked. So sometimes there is a grey area, and I think I do appreciate that, you often will have to accept that, you're playing a mixed role, to try and keep the practices happy, but also to try and serve the role that care coordination is really there for as well. And it puts a real complexity on it, doesn't it, Darcie? It makes
It
it
does.
hard for people, doesn't it?
Yeah, it really, really does. And it's like I say, it's care coordination it's a massive role. It's a massive scope to it because no two people work the same. And it's like I say, particularly with PCNs, around our area, we have some PCNs that will have 4,000 patients with two care coordinators. We have 32,000 patients all under one roof with six care coordinators that deal with different things. It's all cohort dependent. If you only have, 50 people on a register, you can provide more personalized care because obviously you've got the time to do so. Whereas somebody that's got a massive cohort might not, but it's all about dealing with what you've got and what you can provide whilst obviously restricting yourself on what your realistic goals are. It's about working it to the way that kind of suits your PCN in a way, but obviously that's determinable by you as a care coordinator, what you're comfortable with, and having a voice to actually speak up about things and define your role within your PCN as best you can.
Yeah, and that's clearly attention, isn't it? People like Nikki who've been in the role for a long time, people like Heather, actually advocating for the role and sticking up for it is really quite important. And I would really encourage you to do that. And that's the value of having ambassadors like Darcie and leaders like Nikki and Heather to try and be ambassadors. So thank you. Emily, I can see you've got your hand up.
Well, I was just an example of how our care coordinator often her job often varies, but it kind of always comes back to a central core of the patients that she's supporting. So she sent me a task. We're on system one. Can I look at exception reportings for QoF? It was about a patient who wasn't on a particular medication that they should have been because of the chronic health that they had. And I didn't I managed to catch her and I said, Helen, what do you need me to do? And she basically says, oh, always at this time of year, I have to go through all the exception reports for the QoF. And she was talking about a patient and we were looking through it together. And I sort of had this like, this is so complex. She was digging around in notes, trying to understand why this person wasn't on this medication. And it was because obviously year end. And so that was her sort of the admin role, but it was very much because she knew the patient and because she had had that contact with the patient at home and understood him. So that kind of that crossover of working with the patient and then sometimes having to do some admin work alongside it. Does that kind of illustrate that role?
Yeah, it just shows
Yeah,
that there's overlap. Sorry,
yeah.
Darcie, come on.
Yeah, I was just going to say, yeah, it does. It just, I was going to say very similar. It does. It just shows that there is overlap between it all. But it's like I say, it's completely definable on the capacity of the care coordinator, what they can deal with. And again, like I'm seeing in the group chat, thinking I'm on WhatsApp, like I can see on the chat, it's a lot of people have background as well. They come into care coordination from a clinical role. Some people might not. Some people might just come into care coordination from, healthcare, being carers and coming in from that aspect. But a lot of the support that people can give sometimes does depend on whether they've been clinical beforehand or not, and whether they have that kind of experience. So it's all completely dependable, if that makes sense.
Yes, it does. I think it does, Darcie. Yes, it does to
Yes.
me.